talking about pain management for children. And at the end of this week, you should be able to discuss pain management in children, identify the barriers to effective pain management, discuss pain assessment tools, and explain the nursing process of how to care for a child in pain. Definition of pain. Pain is whatever the person experiencing pain says it is, existing whenever the person says it does. Infants and children are often unable to communicate the presence and location and type of pain. Pain is very individualized. One person's experience of pain may be different to another's. So, what we think should be painful may not to another, and we shouldn't we should be very cognizant of how we perceive pain and how others perceive pain, and keep our own biases to ourselves. Types of pain. Acute pain is sudden onset, continues for a limited time, usually caused by trauma, invasive procedures, surgery, non-accidental injury from child abuse. It could persist into chronic pain. Chronic pain continues for unpredictable period beyond expected recovery period. It's unlikely to resolve quickly and may adversely affect the child's daily activities of living. There's one more form of pain. It's called neuropathic pain, and that's a complex type of chronic pain to treat. The World Health Organization developed this ladder in 1980, and it was a three-step analgesic ladder to improve treatment for cancer pain. Their first tier would be always start with the non-opioid analgesics for mild pain, then going to the weak opioid for mild to moderate pain, and then finally the opioid analgesics for severe pain. And these guidelines are the basis for pain management of children and adults, particularly related to multi-drug therapy. It's obstacles in pain management in children. So the myths associated, and the greatest two myths that I see in practice, is fear of respiratory depression and fear of addiction. Oftentimes you'll have a deficit of knowledge of the parents of what they consider to be too much pain medicine, or they don't need, or their child doesn't need pain medicine because they feel like what they've experienced is not worthy enough to need pain medicine for. So the barriers to pain management is the perceptions of the parents and the nurses taking care of the patient. It is difficult to manage pain in preterm neonates because they don't produce specific responses to acute pain on a consistent basis. Nonverbal patients, pain assessment is based on observed behavioral and physiological responses to acute pain. And significant variability in the subjective interpretation of an infant's pain level by different providers. That's where the inaccuracy of assessment comes in. If you have one provider rating the pain scale, the FLAC scale, for example, a 10 on an infant, but another provider says it's only a 2, there's a discrepancy. Or if they're using different pain assessment tools to rate the pain level, that is where you're going to have inaccuracies of assessment. And oftentimes the inaccuracies of assessment come from in the clinical setting, in the hospital setting, where you have different nurses assessing the patient using different tools, not using the same tool every time. And that's where you can get into problems with not being able to manage pain appropriately, and also including their own biases into that, or allowing the parent's perspective of saying the child is not in pain when you can clearly see the child is having difficulties managing pain in their comfort level. The lack of awareness of pain management interventions, that can be a problem as well. And oftentimes the knowledge deficit insufficient awareness of pain management interventions, lack of confidence regarding efficacy of pain management, lack of communication with patients and their families, personal attitudes and beliefs about pain, all are obstacles to pain management. And I see it in the clinical setting all the time. And our own biases need to be set aside for delivering appropriate care to our patients. Oftentimes determinants of the long-term outcomes of infant pain is their timing, degree of injury, and analgesic use. Concern for older children and their memories of painful experiences will often impact and be an obstacle to pain management. Negative reactions to painful events and poor acceptance of interventions later on. So whatever their experience was in the past of pain will come into play again at their current experience with pain. So when we look at influences on pain assessment, we're looking at developmental level of the patient and emotional status, cultural and ethnicity, because that will play a part in whether the family and the child themselves believe in using any analgesic to manage pain. Certain cultures don't believe in it. Previous experience with pain we just discussed. So whatever experience they had previously, they will bring that to the forefront of their current experience, and oftentimes there'll be more resistance to or anxiety because of what their past experience was like. How long have they been under such pain? Was it just a minor surgical procedure? Is it chronic pain? Children with chronic pain tend to not exhibit noticeable behavioral changes like one with acute pain would. Parental response to child's pain is a big one in terms of their perception, in terms of their willingness to allow you to give them pain medicine. Personality type, are they more a sensitive temperament to not be able to tolerate pain? They have a low tolerance for pain, which will factor in to the need for pain medicine or not. So assessing pain is a multidimensional and subjective. We're going to talk now about the assessment according to the developmental level. So neonates and infants. They're difficult to manage pain in preterm infants because they don't produce specific responses to acute pain on a consistent basis. Because of their immature central nervous systems, they feel pain, and if left untreated, can experience long-term negative consequences. Infants may have a lower pain threshold and perceive pain more intensely than older children and adults because of immature control mechanisms in the nervous system that limits their ability to modulate the pain experience. Assessing acute pain is primarily based on behavioral and certain physiologic indicators. Rapid changes in behavioral state and sleep activity patterns signal the likelihood of pain. Behavioral indicators of pain, crying, fist clenching, grimacing, wrinkling of forehead, fussiness, and restlessness. Facial expression is the most consistent cue available when judging pain in infants and children. Cries associated with pain, more high-pitched, tense, harsh, can be indicators of pain. Total body response when a neonate responds to painful stimuli. Pain scores are higher and behavioral changes are greater when infants are awake and active compared to when asleep. When we talk about toddlers, they tend to cry longer than an infant, can verbalize displeasure when a painful experience occurs. Generalized restlessness guarding the site, touching the painful area are signs of pain in the toddler. They may avoid eye contact. Facial expressions can indicate fear or anger, and they may exhibit regression. Schoolers are very egocentric. They are able to describe the location and intensity of the pain. They think pain will magically go away. They fear bodily mutilation. Cry and struggle to escape from the procedure. They can also regress. School-age children describe pain and relate it to a particular body part. They can quantify pain intensity, understand the need for painful procedures. They too fear bodily harm and have awareness of death, may overreact to illness or injury, remembers previous painful experiences which affect the current response, may exhibit a stiff body posture, withdraw, or quietly sob. If they resist treatment, they cry loudly or act out aggressively, may procrastinate or bargain to delay a painful procedure, and they may also regress. Adolescents can describe quantity and location of the pain. They can think abstractly and understand cause and effect. They can discuss strategies of how to deal with the pain, able to perceive and understand pain at a physical, emotional, and cognitive level. Regression may occur as well with this age group. They tend to be very egocentric still, tend to think others focus on their behaviors, and may suppress manifestations of pain. They may exhibit fewer outward signs of pain. When we talk about pain assessment tools, we need to be consistent with the pain assessment tool that we're using, and that it's developmentally appropriate for the child based on their age. It provides objective data, reduces the chance that discrete signs will be missed, should correspond with the child's developmental abilities. Tools for infants and pre-verbal children, the tool is used best is the FLAC. FLAC consists of the face, legs, activity, cry, consolability, each scored from 0 to 2, with a total score from 0 to 10. This is good for infants who are pre-verbal or nonverbal children. The poker chip tool, the FACES pain rating scale, are tools used for preschoolers and school-age children. The FACES has 6 cartoon faces with neutral or gradually increasing painful expressions. It goes from 0 to no hurt to a crying face 5 or 10. And this is for children 3 years and older, best used for. You want to give the same assessment tool each time a child is being assessed for pain. And the other more common assessment tool is the numeric rating scale, which it can use for school-age children and adolescents. It's a number that reflects the pain level from 0 to 10. And most often this is used for children 9 years old and older. This is just an example of the FACES cartoon assessment tool that we use in the hospital. Non-pharmacological interventions for pain is first distraction, and it's focusing the child on the distraction rather than on the pain experience. So you can, it has to be developmentally appropriate for the child, and it's very easy to use. So that could be offering to play a game or arts and crafts with them, taking their mind off of their painful experience by directing it onto a different technique, onto a different experience. Regulated breathing. This provides a focal point for distraction and produces relaxation. It's a simple mode to achieve. And it teaches the child to achieve a slow, rhythmic breathing pattern. And parents alike can be taught how to use this technique. Guided imagery is used to help the child imagine the sounds, sights, and smells of an enjoyable item or experience, such as playing in the water or a birthday celebration. The facilitator talks in a soft, calm voice while guiding the child's imagination. This too can be coupled with relaxation techniques such as rhythmic breathing. Acupuncture, very effective for acute and chronic pain in children. It has to be done by a trained acupuncturist, and there may be some needle phobia with this because of the use of very thin needles that are applied to the skin. Topical heating and cooling provides pain relief and comfort, and very simple to use, and oftentimes just doing the simple technique can also help alleviate the pain and provide a distraction for the infant or child. Massage is another form of non-pharmacological treatment, And the purpose is to manipulate the body, providing tactile and kinesthetic stimulation. This is performed typically by massage therapists, but nurses can too provide basic massage. It also helps to reduce anxiety by doing massage. The TENS, which is called transcutaneous electrical nerve stimulation, provides a small amount of electrical energy delivered to the skin via electrodes. It can completely or partially block the sensation of pain in the stimulated area. It's usually administered by physical therapists, and it's used frequently for anybody with chronic pain or neuropathic pain. Non-nutritive sucking on a pacifier, skin-to-skin contact, that can be used during and or after a painful procedure. Non-nutritive sucking on a pacifier, skin-to-skin contact with the infant positioned directly on the mother's chest, holding and rocking by a parent or caregiver, tucking or swaddling where the infant is wrapped with the extremities close to the trunk. Infant kangaroo is effective at reducing pain by the mother. And it gives the parents hands-on involvement and a sense of control with their child. Giving sucrose with non-nutritive sucking before and after a painful procedure are safe and effective at reducing pain. B. Children may not admit having pain. When we talk about pharmacologic interventions for pain, we talk about analgesics, patient-controlled analgesic and topical anesthetic agents. And analgesics can be administered through an epidural, subcutaneous, intramuscular, intravenous, topical, oral, rectal, intranasal, transdermal. When we talk about patient-controlled analgesia, most effective way to administer opiates, it's patient controls the infusion. And you have to monitor the pulse oximetry, cardiac, and respiratory status continuously. And have on hand Narcan, which will help reverse opioid-related analgesia and respiratory depression. Pain assessment has to be utilized every 1 to 4 hours whenever a bolus is given to effectively manage with the PCA therapy. PCAs are typically good for children 5 years in age and older. When we talk about topical anesthetic agents, we're talking about reducing pain associated with invasive procedures such as injections, venipunctures, lumbar punctures, bone marrow aspirations. It's lidocaine, prilocaine, 5% cream is used for invasive procedures. That can be used for circumcisions, that can be used for venipunctures to get blood from the child. They also have another topical anesthetic called cold spray, and it provides immediate numbing to the skin that will help you perform the necessary blood work. And then when we talk about opiates, the dose is determined by the body weight, physiological development, and medical situation. It does not have a ceiling effect, so further dose is titrated based on the child's response. It can produce sedation and respiratory depression, and that's why the child needs to be monitored. If given IV, needs to be monitored with oximetry, cardiac, and apnea monitor. And then we talk about procedural sedation. And that really is a medically controlled state of depressed consciousness that allows the patient to respond appropriately to verbal and tactile stimulation, but yet maintain oxygenation and airway control independently. The child is able to retain protective airway reflexes. And the continuum of sedation levels ranges from minimum to moderate and deep. And it's generally achieved through IV administration, such as things like propofol, which is a short-acting analgesic that once you shut off the infusion of propofol, the child wakes up. Multiple routes can be used for procedural sedation. It can be IV, intranasal, rectal, IM, oral, or sublingual. The care has to be under an anesthesiologist or trained physician or nurse anesthetist in order to administer procedural sedation. And so the nurse must administer and monitor patients receiving sedation agents by documenting and assessing their vital signs, oxygen saturation, and level of consciousness both during and after the procedural sedation. So administering analgesics to children, the preferred routes are intravenous, IV, or oral. Typically, after procedure, the medication's given IV because it's faster acting and pain relief can be relieved much sooner than oral. But as soon as the child is able to take oral medications, the child will be switched off of IV to the oral pain medicine. Again, infants and children receive IV and epidural opiates should be monitored by pulse oximetry and apnea monitor. And if respiratory depression occurs with opiate use, Narcan should be used for reversal when oxygen and stimulation of the child is ineffective. A child's perception of pain is influenced by the A. Parental response to the child's pain, B. Child's ethnic background, C. Child's developmental stage, D. All of the above. And the answer is D. All of the above. Which statement about children in pain and its management is true? A. Children can easily become addicted to opiate analgesics. B. Children who are playing are not in pain. C. Past experience affects how a child experiences pain. D. Children are more likely than adults to experience respiratory depression from narcotics. The answer is C. Past experience affect how a child experiences pain.